We are the Society for Healthcare Innovation. Today we have Ruth Krystopolski, the VP of Population Health at Atrium. Ruth, could you give us a bit of background about yourself and speak a little bit about how Atrium is addressing this pandemic from a population health perspective?
Years really starting in the space of quality and had participated through two CMS HENs, so Hospital Engagement Network, and then Hospital Improvement Network work. And then that really transitioned into a platform for thinking about how do we provide value to the communities and the populations that we serve. So really thinking about cost and quality across our broad geography. So I've been with Atrium Health for about 4 years and really was the first person to lead the population health program, and am the first person to lead the population health program, really looking at people, process, and technology to support better outcomes for our patients and for our communities. And I can tell you, this is year number 30 for me in healthcare, and the COVID pandemic has, I think, been quite an experience for me, as it has for a lot of folks in healthcare. I think it's presented a whole host of challenges, but also an opportunity to move some of the work that we've been iterating on significantly faster. And so Atrium, as an example, was historically strong in delivering services using virtual technology. I think the regulatory environment, the payment environment, and quite frankly, the consumer acceptance environment all hindered our ability to go broad and deep in the virtual space. And so we had really strong virtual ICU programs. We use a lot of virtual in the behavioral health space, both integrated in primary care, and then everything from telepsych to managing individuals in inpatient settings. And so the COVID really kind of lit virtual on fire, and we did our entire volume for 2020 in virtual from in the month of March, right? And so thousands and thousands of visits virtually, and we converted almost in 3 weeks, the majority of our ambulatory patient volume and some of our specialty care from in-person care to virtual care, literally in 21 days. And if we would have not been in the pandemic, that my guess would be that we would be for years from now still kind of iterating across either specialty services or service lines or particular patient segments. So I do think COVID's lit a fire on use of technology and forcing us to innovate. And that's been a tremendous opportunity. We've also looked at how do we extend capacity. Atrium has capacity challenges without COVID, and with COVID have really bumped up against our ability to care for people in inpatient settings. And so teams of folks have put together workflows, processes using technology to support really caring for COVID positive patients virtually, both using technology to engage those people that have been exposed and are positive but need just a little hand holding, and even some lower level medical patients, and actually managing them in the home. And so we've been able to manage several thousand people using technology. And I think this morning we have almost 30 people that would have been inpatients in our facilities that we're managing in their homes. And that has, benefits from the patient perspective. When they're in our facilities and they're COVID positive, they can't have visitors, right? I mean, they're pretty much isolated from their families. Now, their families need to be careful when they're interacting with them in their homes, but at least they're in their home setting comfortable, and we're reaching into where they're at, which is better for them. And then, quite frankly, we're limiting exposure to our staff by managing them at home and using technology. So lots of really cool innovative work occurring And we've been able to use the data that we've collected over the last 4 years and the platform technology that we've put in place to identify people that are at high risk for COVID, high risk for complication, and then use that to drive a lot of our reach out. So really kind of kick-started a lot of our innovation and how we're engaging patients.
I wanted to touch on one of the last things you said, right? I mean, we know from New York that 88% of admissions were folks with one or more chronic diseases, and 95% had two or more. And you mentioned that kind of proactive approach to the chronic populations. How are you viewing that and addressing the increased risk factor for these folks, as well as the fact that they're probably less likely to come in because of their vulnerability?
Yeah, so we did do some proactive panel management, and early on, I'm guessing we were probably 2 or 3 weeks in, so middle of April, really started to look at the number of people who had canceled appointments and who were canceling appointments, in-person appointments. And what we did was we went into our data sets and pulled those individuals that met the chronic disease profile of individuals who would be complicated by COVID or by not receiving continuing care. And then we provided that information at each of our clinics, and we have a broad primary care base that's integrated into Atrium, and then helped with back office support for reach outs from the physicians to the patients directly to engage them in either a virtual visit using two-way technology. But in many cases, we did a lot of what we called virtual check-ins, which were audio-only visits. The concept of video and virtual seems really cool to a lot of people, but we have large portions of our population that don't have either access to internet, the bandwidth, or quite frankly, the data packages in order to engage with a video part of the component. So really doing what we could to get to individuals, make sure they had testing and some of basic needs met. And so as we were finding COVID positive patients and sending them home, if they needed paper supplies or food, we were hooking them up with community service. So really a proactive reach out on our most vulnerable patients.
Great. And so in light of that, do you feel that you guys have done a good job of mitigating this potential quote unquote second wave coming from chronic patients, or because so many of them are not technologically hooked up, do you still worry about that fallout?
You know, I think there's still a tremendous amount of fear. There are some technology issues that we have. You can't get a hemoglobin A1C without a lab test, right? And so you have to get somebody somewhere to get that done, or we need to get the test to individuals. And so we still have some challenges on getting the information that we need for the patients. But I think we're being really creative in setting up additional drive-through test sites across our community to collect things, even mailing things to people's homes and asking them to give a urine sample or do their, Cologuard and send it back. So I think we're trying to use some reach outs to not drop the ball. But there is, and our data suggests there are suppressed volumes in places that you would go, that doesn't really make sense. So the number of people that are presenting with chest pain, as an example, has gone down significantly. Now, I probably have more anxiety than I had before, so I might have more chest pain, but it doesn't seem to match what's going on. So I think we're going to continue to learn and reach out. And I don't think of waves anymore. I think we're going to be in a protracted period of time for the next 18 to 24 months where we're going to have to think creatively to meet the needs of our patients. And it feels like there's not waves. It just feels like we're on the beach and it's crashing against us. So but I think we're going to learn, right? And we don't even understand what the long-term impact of COVID is on patients, right? So there's that whole, what's the third wave of the, unintended consequences of, the pulmonary issues some of these patients might have, and other clinical sequelae as a result of, being really sick. So we've got, I think, years of learning in front of us.
That's a great and troubling point.
Yeah.
The other thing that this pandemic has cast light on is obviously the socioeconomic disparities in this country that affect access to care, quality of care. When we spoke last time, you had mentioned some interesting measures that you guys have taken even before this pandemic to reach out to those populations. And I was hoping you might be able to speak a little bit to that.
Sure. I mean, we've had a tremendous focus around what I would call our, comorbid conditions of poverty across our broader footprint, and then addressing some of those. Now, in some cases we're the provider, in some cases we're the convener, in some places we're providing advocacy to really start to think about how do you address issues that impact health that are outside of, quite frankly, the purview of the healthcare system. And so we have used technology to build and connect access to social support organizations across our footprint, and use that with our patients directly, and then with our care management and physician leadership to connect people to social services. And we started that program 4 years ago, and we do thousands of referrals of patients. And I think it allows us to partner with organizations that are set up to do things like deliver food or find housing. We've also spent quite a bit of energy around taking services into the communities where they're needed. And so using some data on testing as an example, we were able to identify that some of our communities of color and of lower economic status actually had testing rates per thousand far less than those that were in, predominantly white and higher socioeconomic class patients. And part of it was, we put up drive-through testing tents, which make really good sense unless you don't have a car to drive through, right? So, we're all learning. So what we did was we repurposed 2 of our wellness on wheel vehicles. So we do a lot of work from a wellness and prevention standpoint in the community, set them up as testing locations, and then using hot spotting and heat mapping of incidence rates, taking the testing into the communities. And we're testing hundreds of patients a day across some of our most challenged zip codes and areas, ensuring that people have access to tests so that they can protect themselves and their family members. So really, the data, though, and then the work that we've done to connect with those communities, whether it's churches or our Latinx Chamber of Commerce, that really helped us support, how do we get care to the people who need it the most, that have been, in our communities impacted far greater than the general population. So yeah, it's we have a lot of work to do. I think we as a country have a lot of work to do, but I think it's this kind of innovative thought process that's going to let us think differently about how we solve some of those health inequities and the causes of them.
Right. You are at the crossroads of population health and disease prevention and management, given your role. And I'm curious, given what you've seen, if you have a sense of how you think our country's healthcare system may shift to address this clear and apparent need for a different way of thinking about population health, especially among underserved populations.
Yeah, I mean, and again, I have my own personal opinions. There's our, organizational opinions. I'll speak personally, again, having, several decades into this. I do believe that access to healthcare should be extended to everyone who lives in our country, and a thoughtful plan. And I'm not suggesting that it has to be, and I don't believe that it should be a public takeover of the health insurance system, but a thoughtful design of a program that ensures that everybody has access to coverage, I think, should be should be on the pathway to beginning to address health inequities, right? And so, I do believe that should be a minimum for everyone. I think we woefully funded public health, and I've not worked in public health. In our population health, it's really about how does the healthcare system address the needs of the population they serve, and doing it in a high quality, low cost way. But I think our lack of investment in a solid public health system is rearing its head through all of this. I think there's a patchwork of mismatches between city, county, state, and federal government, and maybe a roadmap on what some basic public health functions could and should be, and the ability to fund those appropriately, or fund the health systems to do it, right? If we don't want to build an additional public health structure, figure out how to get the funding to the large health systems across the country to help, fulfill that role. Because right now we're doing it and, as a requirement, but not really, having, quite frankly, the reimbursement for it. So I think that's important. And then the final thing, I think we need to attack poverty as a nation, right? And, a lot of the issues that we have with regards to poor health outcomes and impacts on individuals' health derive directly from poverty. So whether it's lack of housing, lack of access to food, lack of access to healthcare, really result from poverty. And so what are some of those things that we as a country should begin to prioritize, whether it's raising the minimum wage to $15 an hour, providing some kind of support systems. I just think we need to think holistically, and put a plan in place and not make it political, right? Because this is about human beings. It's not about political parties. So let's right for humans. It sounds really easy. I know how hard it is, but I do believe that we have the capacity to do it. The final thing that I've learned through all of this, which could also help in addressing some of the poverty, is I think we need to onshore a lot of our supply chain. I think it's a huge health risk. I think it's a huge country risk. And we all play into buying stuff from the cheapest outlet, whether it's tennis shoes or surgical masks, right? I mean, we're all pushed to get the lowest unit cost. I think for drugs, medical supplies, medical equipment, some of these things are vital to caring for our country. We really need to start to have a thoughtful onshoring process so that when this happens again, because it will, there are a lot of bodies on the globe, and we're going to have other issues. We'll have the ability to address it without having instability across the globe impact the people who live in our country. So that's what I think about when I think about how we might do things differently for the future.
Well, Ruth, thank you for sharing your thoughts, and thank you for taking the time. I know you're extremely busy. Again, we are the Society for Healthcare Innovation. Thank you so much for joining us.
Thank you for having me.